So let's now proceed to the disorders associated with the insulin production. So one of the major diseases associated with the deficiency in the production of insulin is diabetes mellitus. So this presentation was developed from these references. So diabetes mellitus is a disease in which the body doesn't produce or properly use insulin, leading to a condition known as hyperglycemia. So diabetes is considered to be a lifelong disease marked by high levels of glucose in the blood. So diabetes, now once the animal has diabetes, it is considered to be a lifelong disease. So once the animal has that particular disease, it is already there for life. And there is no cure for diabetes. So in animals with diabetes, the pancreas either produces little or no insulin, or the cells do not respond to the insulin that is produced. So the glucose builds up in the blood. So the condition wherein the glucose is present in the blood in higher amount is known as hyperglycemia. So as a review of the different pancreatic hormones, so we have two major pancreatic hormones that is produced in the pancreas. We have the insulin and the glucagon. So the insulin is basically produced from the beta cells. It stimulates the uptake of glucose by the body cells, thereby decreasing blood levels of glucose. The glucagon, on the other hand, is produced by the alpha cells. It stimulates the breakdown of glycogen and the release of glucose, thereby increasing the blood levels of glucose. So as you can see here, the insulin and glucagon have opposing functions. So insulin is basically an anabolic hormone because it promotes the uptake of glucose and the storage of glucose in the body cells. Whereas the glucagon here is a catabolic hormone because it stimulates the breakdown of glycogen and the release of glucose into the blood. So glucagon and insulin work together to regulate and maintain the blood sugar levels. So we have here a diagram showing the action of insulin on the cell metabolism. So we have here a normal cell and it contains insulin receptor. We also have here the presence of the glucose transporter. This one here is a closed glucose transporter. We also have here the presence of an open glucose transporter. In the ECF, we have here on the yellow one here represents the insulin and the bluish one here represents the glucose. So in the presence of glucose, the pancreatic beta cells will release insulin into the blood. And when insulin will bind to the insulin receptors that is located on the pancreatic beta cell membrane, it will stimulate the uptake of this glucose here that is present on the ECF towards the inside of the cell. So let's first go back to the functions of insulin. So one of the major functions of insulin is that it enables the glucose to be transported into the cells for energy for the body. It also converts glucose to glycogen to be stored in muscles and the liver. Insulin is also important to facilitate the conversion of excess glucose to fat, and it also prevents the breakdown of body protein for energy. So we have here a diagram now showing the anabolic effects of insulin. So insulin is important for the cells or for the tissues such as the skeletal muscle, the liver, adipose tissue, because it will promote glycogenesis and increase protein synthesis, for example, in the skeletal muscle. In the liver, it will also promote the formation of glycogen, so that is the glycogenesis, and it will decrease the gluconeogenesis. In the adipose tissue, it will increase adipogenesis and it will decrease the lipolysis. So when we are going to evaluate or to assess the major metabolic function of insulin, so it basically is an anabolic hormone. So it promotes anabolism or tissue build-up by way of the synthesis of glycogen, protein, and fat. So what goes wrong in diabetes? So there are a multitude of mechanisms that are involved in the development of diabetes mellitus. So first is on the insulin itself. So basically in diabetes, there are some abnormalities in the regulation of the production of insulin. There can also be abnormality or a disorder in its secretion. So when there is a disorder in the secretion of insulin, so there would be a problem with the uptake of glucose into insulin-sensitive cells. Because as we have earlier discussed, insulin is important now for the uptake of glucose into the cells. When there is also a problem with the insulin production, it can also lead to the breakdown of certain compounds, such as fats and proteins. In diabetes, diabetes can also result from a damage in the beta cells. And as we all know, the pancreatic beta cells are the major cells that are important for the production of our insulin. So this slide here represents the frequency for dogs and cats developing diabetes mellitus. So for dogs, they have the frequency of 1:100 for developing diabetes mellitus when they reach the age of 12 years old. So this means that for every 100 dogs, there is one dog that will develop diabetes mellitus when that dog reaches 12 years old. For cats, the range is from 1:50 to 1:100, meaning that for every 50 to 500 cats, there is one cat that may develop diabetes mellitus. So the prevalence of DM or diabetes mellitus will increase over time. So this means that the frequency or the prevalence of cats and dogs developing diabetes mellitus will increase by age. So this is more common for the aging population. It is also more common for obese or overweight animals, and also for sedentary lifestyle or physical inactivity. So this slide here represents the signalment of diabetes mellitus. So signalment are important factors that will help identify or diagnose diabetes mellitus. So for dogs, the incidence of diabetes mellitus is more common in females than in males, in a ratio of 2 to 3:1. So this is more common for ages 7 to 9 years. For cats, more than 95% occurs in ages that is more than 5 years of age. And this is also more common in male cats. Majority of cats developing diabetes mellitus are overweight and few are underweight. These are the genetic predisposition of diabetes mellitus. So these are the breeds of dogs and cats that are more predisposed to developing diabetes mellitus. So this slide here represents the etiology of diabetes mellitus in dogs. So first are the risk factors. So included in these factors are the genetics. So there are certain breeds of dogs that are more predisposed or susceptible to developing diabetes mellitus. Environment. So this could include the type of diet that the dog has. We also have different drugs that are antagonistic to insulin. So for example, we have here the glucocorticoids and the melangestrol acetate, as well as the diseases such as pancreatitis. So we have here one of the drug that is antagonistic to the action of insulin is the glucocorticoid. So the long-term use of medications containing glucocorticoid is a risk factor for diabetes. Glucocorticoids promote gluconeogenesis in the liver, whereas in skeletal muscle and white adipose tissue, they decrease glucose uptake and utilization by antagonizing insulin response. Therefore, excess glucocorticoid exposure causes hyperglycemia and insulin resistance. You also have here the drug melengestrol acetate. So melengestrol acetate is a progestin. When we say progestin, that is a synthetic form of progesterone. So this is classified also as a corticosteroid or glucocorticoid. And this particular drug will elevate also the blood sugar. Another factor here is the presence of disease such as pancreatitis. So pancreatitis could lead to complications including diabetes. Another risk factor is the immune-mediated destruction of the islets. So this can occur leading to beta cell dysfunction or the beta islet dysfunction. So when there is a dysfunction of the beta cell, so this could result to a relative or absolute deficiency of insulin. Now, because the beta islet cell are the cells that are producing the hormone insulin. So it is said that diabetes mellitus in dogs has a slow progression. So likely more than 90% of the islets are lost before DM occurs. It is also considered as the most common disorder of the endocrine pancreas in dogs. In cats, so most of the diabetes mellitus in cats is type 2 in nature. So this is also multifactorial. So one of the risk factor associated with DM in cat is obesity. So obese cats are 4 times more likely to develop DM. Another is pancreatitis or the inflammation or the infection of the pancreas. Genetics. So there are some breeds that are more predisposed. We also have drugs, glucocorticoids or corticosteroid and progestin, such as melengestrol acetate. We also have the amyloidosis of the pancreatic cells. So another is the factors that lead to impaired insulin action in the liver, muscle and adipose tissue, and the beta cell failure could also lead to the development of hyperglycemia or the increase in the blood glucose level. If some beta cell function exists, diabetes may be transient. So there are 2 major types of diabetes. We have type 1 diabetes and type 2 diabetes. So what is this type 1 diabetes? So type 1 diabetes results when the body's immune system destroys its own beta cells in the pancreas. So because the beta cells are the ones producing insulin, so there is no insulin production, would be possible in this type of diabetes. We also have another type, which is the type 2 diabetes. This results from either insulin resistance. So when we say insulin resistance, that is the inability of the cells to use insulin, which inhibits the cell's capability to absorb and then to use glucose in the metabolic process. Another is the type 2 diabetes can also result from inadequate insulin production or a combination of these two, insulin resistance and inadequate insulin production. So this is a schematic diagram representing the type 1 diabetes cell. So in this cell, we have here the presence of glucose transporters. We also have the presence of insulin receptor and the presence of glucose in the extracellular fluid. So in this type of cell, in this type of diabetes, Insulin is absent, no, so because there is an immune-mediated dysfunction, no, in the beta cell. So the beta cell is being destroyed by the by the by the cells, no, immune system. So the beta cells would not be able to produce the hormone insulin, so that when there is no insulin, there would also be no uptake, no, of glucose towards the cell. So the glucose here will not be able to enter the cell, so it could lead to the presence of hyperglycemia, or the increased in the level of glucose in the blood. So for type 2 diabetes, the insulin levels may be normal, elevated, or depressed. So this is characterized by insulin resistance. So in insulin resistance, now the cells do not respond to the presence of insulin, so the glucose stays in the blood. So at this type of type 2 diabetes, so there is insulin, no, but the problem is that the cells do not respond to its presence, so that in this case the insulin level may be normal or elevated. There is also diminished tissue sensitivity to insulin, so that is the insulin resistance. It can also result from impaired beta cell function. So when there is impaired beta cell function, the insulin levels is depressed. These are the risk factors, no, associated with type 2 diabetes. So number one is the family history. A sedentary lifestyle or an inactive lifestyle, no, could lead to type 2 diabetes, obesity, and aging. So type 2 diabetes is more common in individuals having a sedentary lifestyle, overweight or obese, and old patients. So what is insulin resistance? So insulin resistance is characterized in type 2 diabetes. So when we say insulin resistance, that is a condition in which the body does not utilize insulin efficiently. So there is insulin, no, in the body, but the body, no, does not utilize it, no, so that it does not utilize, no, the insulin efficiently, so that the glucose, no, stays in the bloodstream. So insulin resistance is the decreased response of the liver and the peripheral tissues, such as the muscle and the fat, to insulin. So insulin resistance is a primary defect in the majority of patients with type 2 diabetes. So this diagram here now represents the type 2 diabetes cell. So in the type 2 diabetes cell, we have here, the presence of the glucose transporter. We also have here the presence of the insulin receptor and the presence of the insulin. So when there is an elevated blood glucose level, in the blood, the insulin will bind to the insulin receptor. But in this case, in type 2 diabetes, there is only a very minimal amount of glucose that enters the cell, so that the glucose here will still accumulate in the bloodstream. So in this type of cell, the cell does not respond to the presence of insulin in the bloodstream. So this diagram here represents the pathophysiology of type 2 diabetes. So during a carbohydrate meal, so in the stomach, the carbohydrate would be normally converted by digestive enzymes to glucose. The glucose will then enter the bloodstream. So in type 2 diabetes, there is a defective beta cell secretion, so that the production of insulin will be depressed. There is also the insulin resistance, wherein these tissues here, the liver, the skeletal muscle, and the adipose tissue that normally take up glucose will now be not responsive to the presence of insulin. So because they are now unresponsive to the presence of insulin, so they will not be able to uptake glucose into the cell. So because of the metabolic starvation, the adipose tissue would tend to promote excessive lipolysis in order to produce energy. The liver would also promote increase in the gluconeogenesis, or to promote the formation of glucose from non-carbohydrate sources. So we have here a comparison of the characteristics of the two types of diabetes. We have type 1 and type 2. So type 1 diabetes has a rapid onset compared to type 2. Type 2 diabetes is more common in overweight patients. Type 2 diabetes also has insulin resistance, or the condition wherein the body does not respond to the presence of insulin. The ketosis is more common in type 1 diabetes. Type 1 diabetes is also autoimmune in nature, plus environmental factors. The type 2 diabetes is strong heredity. For the treatment, diet and exercise, progressing to tablets and insulin or the treatments for type 2 diabetes. For type 1, this is treated with insulin, diet, and exercise. So this diagram here represents the diabetic metabolism. So in diabetic patients, there is a decrease in the cellular uptake of glucose. There is an increase in the protein catabolism, and there is an increase in lipolysis. So when there is a decreased cellular uptake of glucose, the glucose will now tend to accumulate in the bloodstream. So there will be hyperglycemia. There will also be glucosuria, or the presence of glucose in the urine. There would also be osmotic diuresis, or this is a condition wherein there is an increase in urination due to the presence of certain substances in the fluid filtered by the kidney. There will also be electrolyte depletion, because in diabetic patients, potassium and sodium would normally be excreted through osmotic diuresis. For increased protein catabolism, increased protein catabolism will increase the plasma amino acid, and the nitrogen loss in the urine would also be increased. For the lipolysis, so this will increase the plasma free fatty acid. There will be ketogenesis and the presence of ketones in the urine, or ketonuria, and the presence of the ketones in the blood, or ketonemia. So this osmotic diuresis here that is brought about by hyperglycemia will lead to dehydration, the presence of ketones in the blood, because ketones is normally an acidic compound, so this will promote acidosis, and ultimately this condition here can lead to the development of coma and death. So we have also here the diagram showing the metabolic effects of insulin deficiency. So first, because insulin is deficient in the blood, there will be a decrease in the uptake of glucose into the cell. So because of the decrease in the uptake of glucose in the cell, that cell would normally respond by increasing gluconeogenesis. So when we say gluconeogenesis, that is the process wherein the cell would form glucose from non-carbohydrate sources. So because of this, these events here would lead to hyperglycemia, glucosuria. Again, there will be electrolyte loss due to osmotic diuresis. So the sodium and potassium would normally be lost in the urine, and there will be polyphagia because there is the metabolic starvation. So the cells won't take up glucose, so there will be starvation, so the body would tend to respond by polyphagia, or eating more, or consuming more food. There will also be increase in the protein catabolism. So again, it will also result to excess in the amino acid used for gluconeogenesis. There is also weight loss and weakness and poor wound healing. Increase in lipid catabolism would result to increase in the NEFA, or the non-esterified fatty acid, production of ketones. No, that is the breakdown product of our lipid catabolism, hepatic lipidosis, and weight loss. So again, when we say ketones, these are substances that the body makes as a result of not getting enough glucose. So in insulin deficiency, the cells, or the glucose would tend to accumulate in the blood, so that the cells are being starved of glucose. So in this case, the cells would tend to respond by producing these compounds known as ketones. And these ketones will be produced through the catabolism of fats or lipids. So these ketones can be demonstrated in the blood or the urine. So high ketone levels may indicate diabetic ketoacidosis, or DKA, which is a complication of diabetes that can lead to coma or death. So these are some of the early signs of diabetes mellitus in pet animals. So the first one here is excessive water drinking, increased urination, or polyuria. So excessive water drinking is due to an increased thirst, or polydeptia. There is also weight loss, even though there may be increased appetite, decreased appetite, cloudy eyes, especially in dogs, and chronic or recurring infections. So these are, the other clinical or the common signs of diabetes. So again, there is an increased thirst that is technically termed as polydipsia, polyuria, weight loss, decrease in appetite, tired and lack of energy or fatigue, vomiting, and cataracts, especially in dogs. So polyuria and polydipsia are due to hyperglycemia and osmotic diuresis. So why there is polyuria in diabetes? So polyuria occurs when we have excess levels of sugar in the blood. So that is known as hyperglycemia. So normally, when the kidney create urine, they tend to reabsorb all the sugar and direct it back to the bloodstream. But in type 1 diabetes, there is an excess glucose in the urine, and that glucose will tend to pull more water and result in more urine. So that is why there is the presence of polyuria in diabetic patients, because of the excess glucose in the urine. So when there is glucose in the urine, the glucose there would tend to attract more water, and this can result to polyuria. There is also polydipsia. So polydipsia is also caused by hyperglycemia. So when blood glucose levels get high, the kidney produce more urine in an effort to remove the extra glucose from the body. So meanwhile, because the body is losing fluid, the brain tells the body to drink more in order to replace the lost water. So that is why there is polydipsia, or increase in the thirst. There is also polyphagia. So polyphagia is the increase in hunger or increase in appetite. So in diabetes, the glucose won't be able to enter the cell. So because the glucose will not enter the cell, so the body can convert the food into energy. So this lack of energy will cause an increase in hunger. So that is why there is the polyphagia. There is also dehydration as a result of polyuria. In dogs, we also have the cataracts, the development of cataracts. So 50% of dogs will develop cataracts within 6 months of diagnosis, 75% within a year, and 80% within 16 months after the diagnosis of uh, diabetes. There is also fatigue, nausea, and vomiting. So diabetes mellitus are also common in cats. So in cats, most are subdued, have a coarse, dry coat, and lumbar muscle mass loss. So some diabetic cats present with generalized weakness, while others have a plantigrade stance. So 10% of cats having diabetes show this or exhibit a plantigrade stance. So when we say plantigrade stance, that is a condition wherein the cat stands on its hocks. This is caused by a combination of different factors, including weakness, hypokalemia, or decrease in the concentration of potassium in the blood, and concurrent nerve degeneration caused by diabetic neuropathy. So for cats having a DKA or diabetic ketoacidosis, so when we say diabetic ketoacidosis, that is a complication of diabetes mellitus. So there will also be icterus or jaundice due to an abnormality in the liver. So what is this diabetic ketoacidosis? So in addition to high glucose levels, acutely ill type 1 diabetics have high levels of ketones. As cells cannot get glucose, they burn fats as an alternate energy source. Ketones are produced by the breakdown of fat and muscle and are toxic at high levels. Ketones in the blood cause a condition called acidosis or ketoacidosis. So this is because ketones are acidic in nature. So urine testing will detect ketones in the urine, and blood glucose levels are also high in diabetic ketoacidosis. So this diagram here represents the pathogenesis and pathophysiology of diabetic ketoacidosis or DKA. So DKA is a result of an absolute or relative deficiency leading to ketoacidosis, volume depletion, and hyperglycemia. Insulin is the primary anabolic hormone that allows peripheral tissues to uptake glucose. In the absence of insulin, the other counter-regulatory hormones will act together to break down triglycerides and stimulate gluconeogenesis. In DKA, the normal state of carbohydrate metabolism, which is driven by insulin, will shift to a starvation state and fat metabolism, leading to the characteristic abnormalities including hyperglycemia, ketoacidosis, hyponatremia, polyuria, and polydeptia. So in diabetic patients, there is normally a decrease in insulin. So insulin is important for the uptake of glucose into the cell. Because the cells will not be able to uptake glucose due to a deficiency or to the absence of insulin, the cells would be starved. So in this way, the body would tend to make a way in order to produce glucose as a source of energy. So when there is a decrease in insulin, the counter-regulatory hormones will be increased. This include cortisol, growth hormone, catecholamines, and glucagon. So they will tend to promote lipolysis. Lipolysis will increase the free fatty acids in the liver. So, and it will also promote the production of ketones, leading to ketosis. Ketosis will result to the development of ketoacidosis and the presence of, it will also tend to promote urine excretion of ketones, and that is known as ketouria. So in the presence of these counter-regulatory hormones, this will also promote the increase in the breakdown of proteins, so that is proteolysis, and decrease in the protein synthesis. The breakdown products of proteolysis will also can also serve as a substrate for gluconeogenesis. Gluconeogenesis is a process whereby the cells would create glucose from non-carbohydrate sources, proteins, and fats. Gluconeogenesis will tend to promote hyperglycemia, and hyperglycemia will also promote glucosuria, or increased in the urine, in the increase in the glucose in the urine. That will also promote polyuria. So when there is polyuria, there is also the dehydration, or the decrease in the blood volume. Dehydration will tend to promote polydeptia, because hypovolemia will stimulate the thirst receptors in the CNS. Increase in the glycogenolysis, or the breakdown of glycogen, will also promote hyperglycemia. So this is just a summary of the pathophysiology of our diabetic ketoacidosis. So in diabetic ketoacidosis, so of course we have here, it can lead to this what we call lactic acidosis. So this can occur when the kidneys cannot remove enough acid from the body. So this is caused by increased anaerobic glucose metabolism and consequent lactate accumulation in the bloodstream. So metabolic acidosis is one of the prominent features of diabetic ketoacidosis. So as ketone bodies accumulate in the blood and overwhelm the body's buffering capabilities, there is an increase in hydrogen ions and decrease in bicarbonate. So cataract also frequently develop in dogs. This is related to a unique sorbitol pathway by which glucose is metabolized in the lens of the eye. So this can result to the edema of the lens and the disruption of the normal light transmission. For the diagnosis of diabetes mellitus, so this includes a fasting blood sugar of more than 200 milligram per deciliter and glucosuria, or an elevated glucose in the urine. We can also use fructosamine. This will support sustained hyperglycemia. Fructosamine is a compound that is formed when glucose combines with protein. And this fructosamine is an important tool to diagnose diabetes. We can also use urine dipsticks for home use if stress hyperglycemia is suspected. For the differential diagnosis of diabetes mellitus, so these are the diseases with similar clinical manifestations with diabetes. So this includes hyperthyroidism, GI lymphoma, hepatic disease, renal disease, pancreatitis, and hyperadrenocorticism. Differentials for hyperglycemia includes dextrose containing fluid, parenteral nutrition, diestrus, and pheochromocytoma in dogs, acromegaly in cats, head trauma, and exocrine pancreatic neoplasia. For the clinical pathology, so we have here urinalysis, renal threshold for glucose. So when we say renal threshold, that is the plasma glucose concentration above which significant glucosuria occurs. Its value is variable and deviation occurs both above and below the commonly accepted threshold or normal threshold, which is 180 milligram per deciliter. So for dogs, the renal threshold for glucose is about 180 to 220 milligram per deciliter. For cats, that is 240 to 300 milligram per deciliter. So upon culture of the urine, it can show up to 40% will have a urinary tract infection without an active sediment. So we have here a diagram showing the blood glucose guidelines for dogs. The concentration of the glucose is measured in milligram per deciliter. So a blood glucose that is less than 50 milligram per deciliter is considered to be below this reading. It can indicate that the dog is hypoglycemic when using insulin. So even without visible hypoglycemia symptoms. So immediate treatment is needed. At this particular blood glucose level, 90, this is a minimum safe value for the lowest target blood sugar of the day when insulin is controlled. 62 to 108 milligram per deciliter is a normal glucose value range for dogs who do not have diabetes. 100 to 180 milligram per deciliter is a target range for diabetics, and 180 is the renal threshold for dogs when excess glucose in the blood spills into the urine. We also have here a higher blood glucose level, 250. This is the maximum safe value for the highest blood sugar of the day. So dogs can form cataracts at this level and need to be checked for ketones using urine strips. At 300 milligram per deciliter, the ketone monitoring is needed. High blood glucose value will increase the risk of the body. At more than 360 milligram per deciliter, the ketones need frequent monitoring due to the increasing insulin deficit, illustrated by high glucose reading. So as the blood glucose value increases, so does the possibility for ketone production. So this table here represents the drugs that are recommended for the treatment of diabetes for dogs and cats. Now for dogs, we have here the NPH. So the NPH is considered to be an intermediate acting insulin, and it is available in human recombinant product. So this is the formulation and the starting dose. We also have the Protamine zinc insulin. This has been extensively used for cats. It is typically given subcutaneously twice daily with a starting dose of 1 to 3 IU per cat. We also have here the glargine. So glargine is used for dogs and cats. So glargine is a genetically engineered insulin analog that has a hormonal action identical to native insulin. So other insulin preparations are Detemer, and this is also used for dogs and cats. We also have here the treatment for non-ketotic diabetes. So it is important to establish euglycemia over time. So when we say euglycemia, this is the normal level of sugar in the blood. So the insulin types that are being used to treat diabetes mellitus are the short-acting ones, the short-acting insulin preparations, the intermediate-acting insulin preparations. We have the NPH, glargine, the PZI, and the Prozinc. For the long-acting insulin types, we have the Ultralente, which is now considered to be no longer available. So the goal of the therapy for diabetes mellitus include the restoration of the normal fasting serum glucose concentrations, normalization of the serum fructosamine, and reversal or attenuation of the chronic complications such as diabetic neuropathy and nephropathy. As in human patients with type 2 diabetes mellitus, the best approach to CAT is a stepwise progression from dietary management to oral hypoglycemics and finally to insulin therapy when islet burnout occurs. So one of the drugs that are used is the NPH, which stands for the neutral protamine hagedorn. So this is also known as isophane. And again, it is intermediate acting insulin given to help control the blood sugar. So this is used for dogs and cats together with Alente twice a day dosing needed with 2 meals of equal calories. So this is the dosage for dogs and cats. We also have the protamine zinc insulin or the PZI. It has used extensively in feline diabetes, and it is typically given subcutaneously twice daily with a starting dose of 1 to 3 IU. So the formulation is U40. It is mostly applied in cats, twice daily dosing. And for dogs, this is not recommended because of the unpredictable onset and the duration of action. We also have the glargine insulin that is used for newly diagnosed cats. Another insulin preparation is the caninsulin. So caninsulin is the first insulin licensed for treating diabetes mellitus in dogs and cats. It is an intermediate acting insulin registered in over 30 countries and has a history of more than 25 years of use in dogs and cats. So it is also known as a porcine insulin zinc injection. Available in U40 concentration, it produces 2 peaks of activity. And for cats, it may produce anti-insulin antibodies. So this is the dosing of caninsulin twice a day. It can be increased by 10 to 15% if there is hyperglycemia and decreased by 25% if the blood glucose is less than 70 milligram per deciliter. So another drug that is used for diabetes mellitus is the Levermer or the Levermer. So it is used in Europe and US. So each unit contains about 4 times as much insulin as others, and the duration of action is about 13.5 hours. We also have the Listpro. So Listpro is a combination of the regular plus the intermediate acting insulin preparation. This is indicated for postprandial treatment in humans. So when we say a postprandial, that is after a meal. So however, subcutaneous regular insulin onset is low and duration of action in dogs and cats is about 5 hours. It has been used to treat diabetic ketoacidosis in dogs. We also have the oral hypoglycemic agents such as sulfonylureas meglitinides, biguanides, thiazolidinidiones, and the alpha glucosidase inhibitor such as the acarbose. So the oral hypoglycemic agents mentioned will only work if functional beta cells of the pancreas are present. Acarbose. So acarbose is an oligosaccharide. No, it is an anti-diabetic agent that will act as an inhibitor of the several enzymes for the breakdown of carbohydrates to the intestine. So this anti-diabetic agent will delay the absorption of glucose from the small intestine. It will also delay the digestion of complex carbohydrates, thus decreasing the hyperglycemia. But it also has side effects such as diarrhea and weight loss. So the cornerstones of diabetes management. So for humans, exercise and diet are considered to be the cornerstone of therapy of diabetes mellitus, particularly the type 2 diabetes mellitus. So in most diabetic cats, exercise is not a reasonable option. So one mechanism by which cats may be encouraged to exercise is by feeding the cat multiple small meals hidden in various places within the house. Now, for example, an obese diabetic cat might be encouraged to jump up on the refrigerator or counter to find the small amounts of food and then have to hunt for the rest of the food at the opposite end of the house. So aside from that, aside from diet and aside from exercise, it is also important to monitor the blood glucose level and of course to administer the appropriate medication. So the primary goal of the medical nutrition therapy is to improve the metabolic control, to maintain the blood glucose level as well as the lipid or the cholesterol level. So in humans and dogs, increased amounts of fiber will slow the rate of glucose absorption from the intestine and will minimize the postprandial fluctuations in the blood glucose. This will allow better glycemic control and correction of obesity. So these are the recommended diet for cats and dogs. Now for cats, low carbohydrate, high protein, and moderate high fiber. And for dog, we have low fat and high fiber diet. Increase in the fiber is also recommended, so more than 12% as slowly fermentable insoluble fiber or more than 8% moderately fermentable fiber. It is also important to maintain short and long-term body weight, prevent or treat complications, and improve and maintain the nutritional status of the animal. Exercise is also important to encourage weight loss and to decrease the insulin resistance induced by obesity.